We'll give it just a second. Okay. Hello, Women's Advantage family. We are coming to you live to talk about research. So one of our core values in the clinic is relentless curiosity, and it's a value that all of us as clinicians really share. And we gravitate to things like looking at the recent research, seeing what is out there that may change the way that we practice clinically. So we are really following evidence-based medicine. So in that idea, we have decided, starting in the month of July, that we will be doing 2 Facebook Live events a month. The first Wednesday of the month and then the last Wednesday of the month. And 2 of our physical therapists, I've got Christina and Vivit here with me today, are going to be kind of tag teaming, having some of these discussions. So on the first Wednesday of the month, we'll be looking at research around our monthly topic. And our topic this month in July is pregnancy. So we're going to look at 3 different studies and kind of talk about those and how that impacts us in clinical practice. In the middle of the month, we're going to be doing a webinar interview of an expert around that topic. So since July's topic is pregnancy, in the middle of the month, we're going to be interviewing a labor and delivery doula and talking about ways to be able to prepare for pregnancy, to feel very confident, especially in today's age of COVID, being able to know and feel confident in how your birth is going to progress, and looking at different birthing positions that are optimal for pelvic floor health, and getting more detailed into actually the birthing process for that webinar. So keep a lookout for that. If you're on our email list, you will be getting an email invitation to that Zoom webinar as well. So let's get started. We're going to be talking today about 3 different topics during pregnancy. One is pelvic girdle pain. The next is development of a diastasis recti, and we're going to explain what all this means. And then the last one is about prenatal exercise, specifically pelvic floor exercise, and how that impacts our risk and prevalence of having symptoms of urinary incontinence in the postpartum time frame. So, you want to get us started with the first article?
Sure. So, with the first article, we're talking about pelvic girdle pain. And so with pelvic girdle pain, you have the pelvis. And so with pelvic girdle pain can be pain in the back here. So you have this sacrum wedged between the 2 hip bones here. And so what overlays the sacrum is lots of different ligaments. And so with the ligaments, you have lots of different muscles that attach here, as well as at the front of the pelvis, you have the pubic symphysis here, and we have lots of muscles that also attach here. So pelvic girdle pain can be pain toward the back here or toward the front. So with pelvic girdle pain, the research talks a little bit about, so just to introduce the research, so our first research study is a study that is a clinical practice guideline. So as physical therapists, or in general within the medical community, we follow different clinical practice guidelines and recommendations that discuss management and treatment of certain conditions. So this one specifically, we're looking at pelvic girdle pain in the antepartum population, and this clinical practice guideline is from a group of experts that looked at different research studies to come up with appropriate management of pelvic girdle pain. And so with pelvic girdle pain, we talk a little bit about, let's see here.
So let's talk about how often it happens.
Yeah.
So the prevalence of pelvic girdle pain is what?
So with the pelvic girdle pain and pregnancy-related low back pain, it's estimated to occur in about 56 to 72% of the antepartum population. So that's quite a bit of people.
That's a lot of mamas having pain. One of the things that I think as PTs we are frustrated with is how often women during pregnancy are being told, oh, your back pain will go away after you deliver baby. Oh, your sacroiliac pain in that posterior part of your pelvis will go away when you deliver baby. That pain in the front, the symphysis pubic pain at the joints here, that'll go away. And maybe if that hurts there, maybe you should have a C-section and not be concerned about injuring that area more during a vaginal birth. And those are all things that we would much rather be treating during pregnancy. Because what the research also shows is if you have more back pain versus pelvic girdle pain, that 25% of people who have low back pain during pregnancy, that pain persists postpartum and doesn't just go away on its own. So we want strong mamas who are able to have a successful birth, who also recover really well. So talk to us more about the study.
Yeah, so not only with what Jenni said about the prevalence, but also the most common time that people develop pelvic girdle pain is around that 14 to 30 weeks of gestation. So
basically the whole pregnancy.
Pretty much the whole
section.
pregnancy. So if we can assess and manage from the beginning, but also when you're thinking about becoming pregnant, these are things to think about. Who is going to be on my team? So you have your OB, midwife, physical therapist is someone that can really hone in from the musculoskeletal and movement standpoint, because what we want for our patients is to be able to be comfortable and move throughout their pregnancy and overall look out for themselves just as much as their babies, because it's important that we do have a successful, comfortable, and active pregnancy as well as postpartum recovery, because taking care of yourself is just as important as looking after your baby during pregnancy and following, to make sure that your needs are also taken care of as well. So if we look at the guidelines here, so different risk factors for developing pelvic girdle pain. So this is something important to take a look at to see what are my risk factors, how can I prevent this from happening, what are things that I can change already that I'm already doing. And so risk factors include prior history of pregnancy, orthopedic dysfunction, so if you have a history of knee pain, foot and ankle pain, low back pain, even neck pain, any of those orthopedic issues will also lead into a risk factor for developing pelvic girdle pain, in conjunction with increased body mass index, so increased BMI. So as you are pregnant and you're getting bigger, obviously your BMI is also gonna get a little bit bigger too. However, something to think about is, as you are getting bigger or prior to pregnancy, what are some ways that I can think a little bit more about weight management, because that's something that is going to be important in your risk of developing pelvic girdle pain, but also overall staying healthy during pregnancy as well.
And I think that's sometimes something hard to think about, is mamas think, well, all right, I'm growing another human, I get to eat whatever I want to eat, and I'll just really worry about losing that weight after birth. I had a dear friend who really kind of felt that way with the first one and had some struggles with gestational diabetes, and she actually gained 100 pounds during the pregnancy. And obviously that is a lot of weight to be losing. But our concern about weight is, are you going to develop a worse diastasis separation in the front? Are you going to develop this pelvic girdle pain or back pain during your pregnancy that then impacts your ability to have a successful birth with the least amount of trauma and intervention that we can get to? So being able to manage weight during pregnancy is an important thing, and thinking about our BMI.
Absolutely. Another risk factor is smoking, and then work dissatisfaction, and overall lack of belief of improvement in your prognosis of pelvic girdle pain. So all things to think about when assessing pelvic girdle pain, but also overall all things that we think about as physical therapists of how can we better empower you to take care of yourself as well. So when taking a look at interventions, we're going to talk a little bit about support belts, exercise, and manual treatments. So the research for the support belts, it has a level D evidence, meaning the evidence is not as strong, not so good. However, that doesn't necessarily mean that it won't help you as a patient. So something that we always value here at Women's Advantage is the uniqueness in each patient. each patient carries their own history, carries their own self and being, of which causes different outcomes as well as different courses of management. So even though the research says letter D for the use of support belts, it may be able to help some more so than others based on what's going on. And so we look at the exercise interventions. And so with exercise can mean a whole lot of different things. So with each patient having their own body, everyone's going to be different in terms of how they respond to different exercises, what type of exercises we might prescribe, and overall what type of exercises are most meaningful to you. And so the level of evidence here for exercise is also D. However, that's not to say that exercise does not help. That's to say that exercise may be helpful, but it will really depend patient to patient on what types of outcomes or what types of exercise you have. And as physical therapists and movement specialists, it is within our role to be able to properly assess our patients, but also prescribe the appropriate exercises for you. And so thinking about those decisions of, during my pregnancy, do I see a personal trainer? Do I see a physical therapist? Do I go to a workout class? All those different things are good. However, as physical therapists, we can better assess you as a patient and overall get a better idea as to what specific exercises you might need in order to maintain your progress during pregnancy or elevate the level of comfort and abilities that you're able to have during that pregnancy. Manual therapy, so we use a lot of manual treatments here. So manual treatments is that hands-on, either fascial release, joint mobilizations, any sort of hands-on treatment. And so the level of evidence for that is level C. However, manual therapy, like I said, is lots of different interventions can be classified within manual therapy. So there's a lot of research that's being done to take a look at the different types of manual treatments. However, as a physical therapist, manual therapy is something that we really use as a facilitator to increase your abilities and comfort with being able to do an exercise, or if we decide that core strengthening might be the right thing for you, how can we get to core strengthening with you being comfortable in certain positions, and how can we facilitate that? So that's where manual therapy comes in our toolbox. And overall, if the evidence says level C, that's not to say that it doesn't help, but overall, acknowledging and appreciating the uniqueness of each patient, it really depends person to person. And I think as physical therapists, we always say it depends, but it's true. It is really true, because each patient is different. And if we didn't say it depends, we would be classifying patients into boxes, but that's not what we do. So anything else you want to add to that?
I think that's a nice lead-in to talk about actually exercise for some things that may not necessarily be pain related, but other structural changes that occur during pregnancy and postpartum. So our next study is looking at diastasis recti. And so when we use that term, women get really concerned about their bellies, those muscles separating open as our bellies get bigger. So if we think about the long muscles that go from the top to your ribs down all the way to your pubic bone, it's two muscles on each side, and there is this connection between them called your linea alba. And that's a thick connective tissue. And as our bellies get bigger and bigger and bigger and bigger, the muscles have to lengthen. But at some point, the muscles go, you know what, I'm done. I've done most of the work. Now somebody else has to take some of the action here. And they start to separate open. So that divot in between the muscles, which usually is about 1.5 to 2 finger widths when you're placing the fingers in this direction, starts to widen out. So during pregnancy, that's something that we want to be watching for and managing, so we can look at improving that control of the deep core in the postpartum period. So talk to me about the prevalence of diastasis during pregnancy.
Yeah, definitely. So with the prevalence of diastasis during pregnancy, so this first statement we have talks about prevalence following delivery, and then we'll take a look at prevalence during pregnancy. But following delivery, it's estimated that 23 to 32% of women present with the persistent diastasis recti 1 year post-delivery. So that's quite a bit. So that 1 year post-delivery, that's a lot of time that you can be spending with getting better care for yourself, but also your baby if you're not able to take care of your baby properly because lifting is really difficult, or you're peeing as you're trying to get back to work after however many weeks. That 1 year persistent DRA is quite a bit of time, and 23 to 32% of women, that is pretty large. So that's something that we can definitely assess and manage early on to be able to prevent that. And so let's see here with the prevalence.
I'm going to back up and talk about the study just
Yeah,
a minute while you're doing that. All right, so this study was done in the UK, and they brought together 21 experts to look at all the research on exercise and diastasis management. And so they looked at all these studies, and their job was to come to a consensus on what are the best recommendations during pregnancy, actually during birthing, which is really cool to think about, and in the early and late postpartum periods. So there were things that while you are pregnant, you can do to help prevent worsening of that diastasis during your pregnancy and then it being persistent in the postpartum period. So do you want to talk to us about some of those recommendations during pregnancy?
Absolutely. So during pregnancy, something that we really emphasize and what the recommendations do support is pressure management. So when I say pressure management, you have the pelvis here and the pelvic floor sitting down here is your body's undercarriage, and you have your deep abdominal muscles, you have your deep back muscles, and your diaphragm. So kind of making up this Coke can cylindrical type shape. That is this pressure system that we talk a lot about. And so with diastasis, it's important that you are managing pressures appropriately. And per the research, avoidance of any sort of static, prolonged posturing. So sitting for long periods of the day, holding your breath as you're doing things throughout the day, all of those different things tie into that pressure management system and avoidance of static posturing for too long.
And I think that's common, that something people do, especially when you're pregnant. You go to lift something, it's a little bit heavier than what you expected. You may hold your breath. And when you hold your breath and you are shutting your glottis here, that increases the pressure all the way from your throat all the way down to your pelvic floor. But we're really also thinking about diaphragm down to your pelvic floor and what's happening there. So if you are repetitively lifting things that are a little too heavy for you, if you have a toddler while you're pregnant, if you're trying to carry all the groceries in at one time, which I think all of us do, if you are constantly repetitively bearing down and bearing down and bearing down, you either can increase your risk of opening in the diastasis, but also not really covered in this study, but also bearing down on the pelvic floor. And it may cause some problems there that either our organs keep being encouraged to go down, or the pelvic floor goes, oh no, I can manage this. I'm going to get tighter and tighter and tighter and help manage all this pressure that you're shoving down there. So it can lead to pelvic floors being a little lax or really overactive. And so two different dysfunctions there and two ways to treat those. But in general, we don't want you holding your breath and doing a lot of straining. So that's one of the biggest preventions, right? During pregnancy. And how about during birth? What can people think about during their birth? Now, this is obviously a vaginal birth we're talking about. Not much you can do during a C-section. So what are those recommendations?
Yeah, so that's a great question. So this is something that you can talk to with your doula, your OB, your physical therapist, your birthing team. A recommendation that is really excellent is the ability to be mobile during labor. So during labor, we want to promote good mobility, not, lying on our back for too long, sitting for too long, anything that promotes moving around the room that you're in will be good. Direct pushing practices that increase intra-abdominal pressure for sustained periods and close the glottis. So we want to avoid that. So pretty much that's to say, when you are pushing, it's important that you establish good techniques and optimization of your pushing strategies, because that will allow for effective pressure management, but also effective pressure dispersion, so that we're not keeping pressure. And also, like Jenni was saying, we're also thinking about the pelvic floor muscles too, sitting as our undercarriage. We don't want too much pressure on those, because other things like prolapse can also happen too.
So no purple pushing. So the holding the breath and pushing as hard as you can, and your face turns purple. And I so remember with my first baby, who had just turned 16, that I was pushing. She wasn't presenting very well. She was actually coming out forehead first instead of crown of her head first, so the widest circumference. And they were really concerned about me being able to get her out. And the nurse finally said, hold your breath and push. And because I had been unmedicated for 21 hours, I did it. And I almost passed out. And I broke a blood vessel in my eye. So you can see, if you hold your breath and push as hard as you can to try to get that baby out, that you can cause other pressures that aren't good for the other organs in your body too. So our preference is not to get to that point of where you're purple pushing or holding your breath, that you've got a little bit of sound coming out, at least a little bit of air exhaling. And if we think about being able to keep the pelvic floor relaxed during birth, using low sounds. So if people make a really high pitch sound, like a ooh, when you make sounds like that, our pelvic floor actually tightens a little bit. So if you can make low guttural sounds during birthing, that actually helps lengthen, elongate, relax the pelvic floor, so it's easier to push baby out. I think sometimes people actually think their pelvic floor helps push the baby out, like it needs to be super strong, instead of the fact that it really needs to be able to elongate and lengthen and relax to be able to let baby out instead.
Absolutely, absolutely. And so with that said, the pelvic floor muscles are really important as they attach to the sacrum here. And so the recommendation from the research is advocate for sacrum freeing rather than recumbent birth position. So birthing positions doesn't necessarily have to mean your only option is laying on your back with your knees open. And this is something to talk with your OB, midwife, doula, pelvic floor physical therapist about, because the uniqueness in each patient also leads to the uniqueness of your birthing position and what your body feels the most comfortable having your baby in. And another thing that the guidelines recommend is advocate for practices that reduce the likelihood of operative birth procedures. So that is something to discuss with your birthing team about, as avoidance of operative birth procedures can be really big in not only your birth process, but also overall recovery period as well.
So when you talk about operative birth procedures, what we kind of think about as PTs is having an episiotomy. So when they cut the pelvic floor, which years ago they thought it actually helped speed up birth, but the research actually didn't support that. So 4 or 5 years ago, ACOG changed that recommendation to not doing episiotomies until a woman had been pushing over 2 hours, or if the baby was showing distress, and then it may be indicated. So our preference being that the pelvic floor can slowly elongate during birth without having that happen. And then we also think about using vacuums or forceps to assist with delivery when babies aren't able to get out. So we want women to be able to relax their pelvic floor, elongate their pelvic floor, maybe use some positions where gravity can assist, like being on hands and knees. Some women do squat position really well, although some of the studies say in the US maybe we're not as good as being in a squat position because we don't squat all the time like in other countries. But those are the things that we work on with patients when they come to see us while they're pregnant, so they can have a successful birth as possible with as little perineal damage as possible. So OBs are really concerned about mama and baby both being alive and healthy at the end, where PTs, we want the quality of life after also to be as good. Obviously respecting any of the medical indications that may say, yes, we need to use a vacuum or forceps here, but trying to anticipate some of those things and prep a mama so she is very confident and successful in doing her birthing as well.
Absolutely. So those are the recommendations for the birthing process. Postpartum, similar to during pregnancy, we want to make sure that we're managing pressures. So the research supports emphasizing static and dynamic postures that reduce excessive intra-abdominal pressure, as well as thinking about within the pressure system that also leads into bowel movement. So when you're straining to have a bowel movement, that's another form of excess pressure that can be put on your abdominal wall and that diastasis and your pelvic floor muscle. So making sure that you're not constipated and that you're able to keep things moving is going to be really important. Avoidance of exercises that concentrically engage the superficial abdominal muscles. So that's just a fancy way of saying sit-ups are probably not going to be the best option for core strengthening postpartum. Do you have anything else to say about that?
No, I would say especially in that immediate postpartum that we really look at the difference between the deep local muscles and the superficial global muscles. And some of those global muscles, especially the external obliques that help us twist and bend, those are able to stay pretty active during pregnancy. So after, they kind of kick right back in, where our deepest core, our transverse abdominis, is so overstretched that it really has forgotten its job per se. And we need to look at, first off, retraining that deep core properly with good coordination and timing, as well as the pelvic floor, before starting to really get concerned about those superficial muscles like the rectus. And that's usually what you're getting when you're doing crunches, is you're getting that rectus abdominis. So there is time for that further out, but in that immediate postpartum, if we're thinking about that fourth trimester, those first 12 or 13 weeks after pregnancy, then really focusing on getting your deep core to kick in properly and getting the coordination, or what we call motor planning, reset is a much more important priority for us.
Absolutely, and that leads into making sure that breath mechanics are also pairing with your movements too. So the research supports making sure that your breath mechanics promote a tension-free diaphragm pattern, meaning with the breath that we're doing, we're pairing it with movement, but also not exerting as much tension on the diaphragm through managing pressures appropriately. And that's something that we'll talk about more during your physical therapy appointments and during your sessions, where we'll really make sure that we're optimizing your breath mechanics with the movements that we're teaching you and the muscles that we're trying to strengthen as well.
So in layman's terms, that is really thinking about coordinating the exhale
on execution.
There you go. Very good.
Yes.
Short and sweet.
Yes. Okay. We want to avoid high impact exercise, as well as exercises in which continence mechanism, so meaning urinary leakage, is not well maintained. And so if you're getting excess urinary leakage with certain activities or exercises, that's something as pelvic floor physical therapists, we can help you out quite a bit with. Okay. So
that manages our front belly. Shall we move on to the last one about pelvic floor?
Yes.
All right.
So go ahead, you can introduce that one.
Great. So what this study looked at, this is a 2018 study, and it talks about urinary incontinence being when a woman has a problem with urine leakage during things like laughing, coughing, sneezing, or anything that increases the pressure in the belly like we've been talking about over the last couple studies. And what we really love about this study is it talks about exercising your pelvic floor during pregnancy and how that reduces risk of postpartum incontinence. So we want to do as much as possible to prep our bodies, so when you go through all of your pregnancy and a birthing process, whether that be vaginal or cesarean birthing, that you have the lowest risk of developing incontinence in the postpartum period. So urinary incontinence, obviously incredibly common during pregnancy even, that 18 to 75% of women are affected, especially in that third trimester period. And then no matter if it was a vaginal birth or a C-section birth, about a third of women still complain of having urinary leakage after birth. And this was a combination of studies, right? They looked at 24 different studies, almost 16,000 women in this study were looked at. So what were some of the findings about doing pelvic floor exercise during pregnancy?
Yeah, so one of the big findings of this research study, super fascinating, is the support of pelvic floor physical therapy and pelvic floor muscle training as a preventative mechanism for avoiding urinary incontinence. And so this study supports that with women who are continent, meaning they're not leaking, pelvic floor muscle training can decrease the prevalence of urinary incontinence during pregnancy as well as postpartum. And so that's to say that with pelvic floor muscle training, we can better help you identify what type of pelvic floor muscle training you need, because pelvic floor muscle training doesn't necessarily mean just Kegels. It can mean strengthening certain types of fibers and coordinating it with certain types of movements to really help with the strength of those pelvic floor muscles.
Right, so those muscles are partly fast twitch and partly slow twitch. So when we cough and sneeze, we want them to kick in quickly, but only about 30% of the fibers respond quickly like that. The majority of the fibers of the pelvic floor muscles, which are any of those muscles that a bike seat would touch if you were sitting, going from the pubic bone all the way to the tailbone and hip to hip in the pelvis. Do you want to show those for me? So endurance, or the ability to hold, not at full capacity, as hard as you can, but a sub-maximal squeeze over extended periods of time is what we find is much more appropriate, and it gives us better outcomes in treating things like incontinence and prolapse. So I think sometimes women read Cosmo, we'll throw Cosmo under the bus, and it'll say you should do 200 Kegels a day. Let's just prevent everything that happens and do 200 Kegels a day. What do you think about that?
No.
Things not to do that you don't even have time to do. Why would you wouldn't go to the gym and do 200 bicep curls, right? So what would you recommend for pregnant mamas if they wanted to prevent urinary incontinence postpartum?
So if you're wanting to prevent urinary incontinence postpartum, identifying the pelvic floor is never too soon. So you have your baby and you're like, I want to do something in order to bring better awareness there and prevent urinary incontinence. So what I like doing with patients is in your chair, thinking about lifting something from your undercarriage. So let's say we're lifting up a blueberry from the chair just between the legs and then dropping it. So that brings awareness to, am I doing this right? Because as you lift the pelvic floor muscles, you should feel those muscles lift away from the chair. And then as you relax them, you should feel them come back down to the chair. And that's how you know you're really getting that good contract and relax of the pelvic floor muscles. So I would say that's a good place to start, and just bringing awareness to the pelvic floor muscles and just getting a good contract, relax associated with, as you're contracting, we're also exhaling, and as we're relaxing, we're inhaling to coordinate the breath with the pelvic floor. And so beyond that, specific pelvic floor muscle exercises and muscle training can be different from patient to patient based on what type of birthing process you went through, but also if you have some pelvic pain following birth and you have a little bit of a scar there, sometimes those Kegels aren't the best option for you right away, because we don't want to irritate muscles that are already in a hypertonic, overactive state due to that guarding, protecting mechanism of following any sort of scarring that happens. Those tissues will guard and protect. So that's something more specific that we will look at as pelvic floor physical therapists to better assess what type of specific muscle training do you need.
And that's in the postpartum stage. So if we were trying to prevent during, when we look at some of the general studies, it says if you want to maintain your strength and work on increasing, doing 30 to 80 repetitions a day of those pelvic floor squeezes. With those, you want to try to hold them. Now, 10 seconds is kind of the gold standard of what we would love, but most people can't do 10 seconds, to be frank. And most of our patients, or at least most of my patients over the last 20 years of practice, actually don't even need to get to a 10-second hold. If they can hold a good 5-second hold, multiple repetitions of that, usually they're quite successful with resolving things like incontinence or prolapse in the postpartum period. So in general, what we look at is saying, if you have no symptoms and you really want to prevent, start with 30 to 40 repetitions, holding that muscle 3 to 5 seconds, and then letting it drop and relax completely. Now we know if we go to the gym and we pick up a weight and we do full bicep curls, we could do that for quite a while. But if we came up and just pumped that end, that muscle would really fatigue quickly. So we don't want to do that to the pelvic floor when we're trying to strengthen. We want to contract it and we want to let it go completely and rest, because we don't want to encourage it to have an overactivity where it's gripping all the time. It's like, you know, those when you have neck pain and you just think, oh, if I could just get that muscle to relax. I'm so used to gripping it up. I had a lovely patient who was a modern dancer, and she was doing a lot of gyrotonics training, which is an offshoot of Pilates. And she was told by her instructor to consider sipping a martini up through a straw into her vagina. And you can imagine those little teeny tiny cocktail straws that she was just like and holding. And she, being a dancer, was very used to holding postures for long periods of time. And so she ended up developing this overactive chronic holding problem, which then dragged her tailbone forward. So if you think about that, these muscles attach in the back to what's called our coccyx, our little tailbone right here, that if you continually engage these muscles, it pulls the tailbone forward towards the pubic bone. So that can happen, or these can become really overactive, like Christina was talking about. And if they can't relax, they become painful, just like our neck muscles. If we contract them all the time, they become painful. We get neck pain, we get headaches. So relaxing those being just as important.
Absolutely.
So I was really fascinated by this new finding.
Absolutely.
Talk about that for me.
So, new findings from this research, they stated that pelvic floor muscle training with aerobic exercise, and aerobic exercise can include walking, reduce the odds of prenatal and postnatal urinary incontinence in women by 50%. So that's quite a bit.
It's huge.
50% is quite a bit.
Yeah.
So with that said, obviously aerobic exercise such as walking, sometimes not everyone is able to get to that because of certain pains or difficulties with just getting around in general. So you're like, okay, how am I supposed to do aerobic exercise if I can't even get up from my chair? So that's something that physical therapists will work on with you, is how can we better manage what's happening in terms of the research, but also overall acknowledging and appreciating you as a patient. How can we better tailor exercise and find something and work together that works best for you and your body during this time so that you can have a more comfortable and active and supportive pregnancy? So aerobic exercise and pelvic floor muscle training is good for avoiding urinary incontinence.
So to wrap this up, one of the things we really want pregnant mamas to know is if you are having pelvic girdle pain, back pain, if you are concerned about this opening of your belly, having a diastasis that you think is getting quite large, or if you want to prevent urinary incontinence postpartum, or even if you're having leakage during pregnancy already and want to address that during pregnancy is a really appropriate time to come in and find a pelvic health physical therapist so you can address those issues. If you're being kind of told and, well, why don't you just wait? That'll probably go away on its own. there's at least 25% chance that it's not going to go away in the postpartum period. So better to address it now and be able to get to where you feel strong and confident and ready to have a successful birth. So don't be afraid to step up and ask your health provider, whether it's your OBGYN or your midwife, to refer you to a physical therapist in your area to help manage those concerns. So I think that is going to wrap it up for us today for the first Facebook Live of the month that we're going to be doing the first Wednesday of every month. And I know it's technically the second Wednesday because July has 5 this month. We're going to be looking at research. So this month was pregnancy, next month is postpartum, and we're changing our topics every month for the next 12 months. The final Facebook Live of the month will be going over any Q&A or further discussion from our middle of the month webinar. So this month it will be an interview of a labor and delivery doula talking about birthing positions, how to best prepare yourself to be empowered and confident in your birth. And so that will be the 3rd week of July, and we'll be sending out via email invitations to be able to get the Zoom link to be on live for that, to be able to do Q&A. We'll also run that live on Facebook if technology is agreeing with us that day. And so feel free to register for that, and we would love to have you there to talk more things pregnancy. Thanks for spending time with us, and we will see you again in a few weeks.
Thank you.
Bye.